Welcome to HealthCast. I'm your host, Melissa Harris, and GovCIO Media and Research is live here at the 2022 HIMSS conference in Orlando. We're here connecting with top health IT leadership and to dive into the details of their work through a series of special podcast episodes with you. Before we get into our interview today, make sure you follow along to GovCast, HealthCast, and CyberCast so you don't miss out. With that housekeeping out of the way, let's jump into the episode. The past couple of years have been incredibly pivotal for transforming the way we navigate and use our health information and data. And the Office of the National Coordinator for Health IT has been working those strings behind the scenes to make it all happen. ONC has helped usher in the adoption of EHRs across the medical space, and recently they've been working on improving U.S. core data for interoperability for improved equity, standing up the Trusted Exchange Framework and Common Agreement to enable National Health Information Exchange, and rules around information blocking, and a bunch more. It's a lot to process, but luckily, ONC's National Coordinator for Health IT, Micky Tripathi, is here to join us at HIMSS to break down some of these strides and how they'll make a difference in the healthcare space. So thank you, Micky, so much for joining us here at HIMSS. It's an exciting conference, and I know you have a lot going on, so it's a special opportunity to chat with you.
Sure. Yeah, happy to be here. Thank you.
So the past couple of years, ONC has hit some really key milestones like the 2020 final rule and last year's information blocking rule, amid all sorts of things. So looking ahead this year, how have these previous steps you've taken going to help lead ONC and the future of health IT going forward?
Sure. Yeah. I mean, a lot of those things were, putting in place to get a process started, and a lot of that is now going to start to actually hit the market in 2020. So 2020 is a really huge year. A number of those things are just to sort of list them in somewhat chronological order. We've got Tefka, the Trusted Exchange Framework and Common Agreement, which we announced is open for network interoperability on January 18th of this year. So that was one thing that we wanted to do a really good reset on and get it out to market as quickly as possible. So that starts the process now of organizations that want to potentially be a qualified network under the Tefka framework to be able to start to really look at the agreement and then decide from a business perspective whether they want to move forward with that. And we've gotten really good indications from the market, so we're really excited about that. And in parallel, we've got as you pointed out, we've got the Cures Act rule, which had a number of different components in it, and now that is starting to kick into place. So we've got on April 5th of 2021, we basically put into implementation the information blocking pieces of the 21st Century Cures rule of the 21st Century Cures Act, and now in so we've had a year, or coming on a year now, where providers, health information networks, and certified technology developers were, required to be in compliance. And this year, we're anticipating a number of other things. One is that the enforcement piece of that will start coming into place, because there isn't right now, because of the way the law was structured, ONC is responsible for creating the policies, which is what we did, and that's what we put into effect on April 5th. But the enforcement, which means an investigation of a complaint that may come into ONC, and the determination of whether that entity is in violation of the 21st Century Cures Act provisions, is the responsibility of the Office of Inspector General. And they haven't issued their final rule yet. We anticipate that'll be sometime this year, and so that'll put in place the second sort of piece of the information blocking puzzle, which is we set the policies, we put it into effect, and then the enforcement piece comes into play as well. The other piece that's really important in 2022 is the API, the requirement that EHR vendors support FHIR-based APIs, which is going to be a real sort of step up for the industry, because you've got the availability of information through APIs today that is required by ONC and ONC regulation related to certification of EHR systems. But we never required that it be the same technical standard, in part because we originally put this into a regulation in 2015. Which was a long time ago, but now the industry has had a lot of time now to sort of spend time making that standard mature and ready for prime time. And now we're very confident that it is ready for prime time. So this year, all the vendors are required to implement that standards-based API for patients to be able to access the information as well as other authorized parties. So a lot of different things going on at multiple levels.
Yeah, sounds like it. And I want to go back to the information blocking piece real quick. So recently, ONC reported, its first sort of block of information of people submitting complaints. It's about one a day, correct?
Roughly
300 something. Yep. So how is you mentioned how OIG is also going to be doing some of the enforcement around it, but based on what you've found so far, how is ONC trying to further enforce information blocking requirements? Is it working with providers to make sure that, they know they shouldn't be doing certain things or should be doing certain things? And also, how does this information blocking reporting system empower patients to control the movement of their health data?
Yeah. So, a number of things. There's a huge need, I think, for as much education and outreach as we can do to patients as well as to providers as well as to others. The technology developers, for example, because they have staffs that spend a lot of time thinking about regulations in particular and ONC regulations because we certify EHR systems. They tend to be more aware of and knowledgeable of these regulations and what the provisions are. But I think the provider community probably is a little bit less aware of the information blocking requirements and the fact that it covers them as well, and that it actually has obligations on them that are separate from the electronic health record system, because we had the meaningful use program for a number of years where providers, I think, got used to the technology supporting what it was they were supposed to do. And so they, basically looked to their electronic health record vendors to provide the capabilities and to, that basically gave them the comfort that, that'll keep me in compliance with whatever I need to be in compliance with. The information blocking, sort of paradigm is different in that the Congress in the 21st Century Cures Act specifically made this about the data, not about where the data lives. And so the obligation on providers is, yes, it's about information that's in the electronic health record that you use, but it's also in information that's in other systems that they use that has what we call electronic health information. So I think there is a need for education and outreach, and that's one of the reasons that we wanted to make that information publicly available. So in particular, what we've been doing is we take complaints. And then again, this was, put into the 21st Century Cures Act that ONC will set up a portal to receive complaints. That's what we've done. That's where these, vast majority of these complaints are coming in. We do an initial screen of them to see if just at face value, does it appear to be, something that could be a legitimate allegation? So for example, was it an actor? Meaning, is it a provider or a health information network or a certified technology developer? So for example, someone could submit a complaint about a payer, about a health insurer that actually is just not covered by the information blocking rules because the 21st Century Cures Act didn't name payers as actors, so as payers. So that would be one example of the kind of screen that we would do to say, well, it's not really an actor, so that isn't one. So we filtered those out, and then and then we have those. So I think the availability of that information, I think, is hopefully one part of being able to communicate to the industry that this is really important. Compliance is really important, and complaints are coming in, and everyone just needs to be aware of, what is it that they're going to do to be able to prevent, further claims and to be able to prevent any of these turning into findings of being in violation. But I do want to point out that, what we've published are just complaints that come in. We haven't, gone through a process of investigation to say, was this an actual violation of information blocking, of the information blocking rule? All we're doing is saying it appears to be a complaint that, at face value, and then it's up to OIG to determine which ones they actually investigate.
Do you see, obviously OIG still has to, take the steps to take action, but if they do, will you sort of follow up based on how they do to try to better educate or enforce information blocking?
Yeah, it's a great question. I mean, so I think independent. So I think there are perhaps two paths here. One is, can we do more regardless of, of what OIG does? And, I think the answer is yes on that front. So, we ourselves are looking hard at, how do we provide more information, for example, to individuals for, how would you recognize information blocking when you see it? Like what should be an expectation that you have as a patient now in terms of, what the law provides that should give you, something different or better than, than the experience you're having today. So, we're working hard and thinking about, how exactly would we, sort of frame that. And it's not just patients. It's also providers who want to be able to get information from another provider. It's a certified technology developer who wants to get information from another system, and they believe that the technology developer on the other end is actually, sort of prohibiting the sharing of information. So, so I think there's more to do in more focused kinds of ways to say, how would you know it when you see it? And I think that's the next step that we need to get to with, with education and outreach. So we're working a lot with provider organizations as well as with technology developers to say, what are you hearing? What are the kinds of questions that people are having? What do you think is the information gap? And then how can we, provide more information on that front? We do have to be a little bit careful because again, the law was, very clear that this was going to be a case-by-case determination based on, the specific facts of the case, and that there's a knowledge standard that's included in that as well. So, what that means is that OIG, in doing its assessment, will also, assess whether it was a reason for whatever, act actually happened. Was it reasonable for that provider, for example, to know that that would have been in violation of information blocking? So all of those, speak to the uniqueness of the individual situation. And what that means is that from an education and outreach perspective, we just have to be careful to not say, here is your cheat sheet on making sure, that if you follow these steps, you will absolutely not be in violation of, information blocking. We're not in the position where we can do that, but we can provide more guidance, I think, for sure.
Yeah, I think the point about how there are different obstacles for different stakeholders across the process is really important, and looking at that holistically. I want to turn to Tefka. You touched upon it at the beginning of our chat here, and I know that it went live in January. So although you've outlined a lot of Tefka in the past, can you sort of talk about what the state of it is right now in 2022 and how it will help expand EHR interoperability across the country moving forward?
Sure. We are at the end of the pre-work and at the beginning of the beginning. And what I mean by that is there was a lot of work that was involved in bringing us to this point, which is, what are the core pieces of Tefka? So just to step back for a second, Tefka is, from the 21st Century Cures Act, Tefka directed ONC to create some kind of governance framework for network interoperability across the country. There are networks that exist today in the private sector, and they've done a tremendous amount of work and do a ton of interoperability. But they've kind of slowed down in terms of being able to move forward. There's still issues of connecting up those networks, and so Tefka is kind of an umbrella that helps to connect them. And the key pieces of that are, people, when they think of networks, they always think of the technical side. So there's technical specifications, but there is no, sort of big switch that Micky Tripathi and the ONC team turn on and all of a sudden it lights up. Basically, the idea of this kind of network is that each network that decides to participate will implement the technical specifications so they can communicate with each other. So there is no big infrastructure on top that manages all the traffic and all the messages and all the medical record information sharing that happens. It really is just an infrastructure to provide security and to provide things like an electronic phone book, essentially, so that I know how would I actually send an electronic message to Mayo Clinic or to Mass General Hospital or to Framingham Pediatrics. I need to be able to have a way to look that up and say, oh, there's the electronic address for them. And then also patient location. How do I know where, Micky Tripathi's records are? They could be in 5 different places, but unless I have some way of finding that out, I don't know, which places to query. So the Tefka superstructure kind of creates that, but the networks communicate, themselves. And so what we've released on January 18th are, the fundamental building blocks of that are the common agreement, which is basically the contract that any organization wants to be a network, signs with, with kind of the network operator, which in our case is a nonprofit organization who we've contracted with called the Sequoia Project. And they basically will enforce these contracts with these networks. So that was the big piece, was putting together a contract that we think will work for the industry, that accomplishes the goals that we want to be able to accomplish, but that is something that, that those who already have networks up and running will see it as valuable to take the next step and, and sign this contract. Because it's a non-trivial amount of work to say, now I've got to sign this new agreement, and now all my users have to, sign, a new agreement. And, that's actually a tremendous amount of work. And there are lots of policy issues and, and things like that. So there was a lot of work in kind of getting enough consensus there for something that still had to go through the, somewhat of a regulatory process within the federal government. So that was a tricky balance that we had to strike, but we're excited that we're able to get that out. And then the other piece is the technical specifications. So what that means, what the launch of it means on January 18th, is that now we can say these are now out in the public. So any network that is interested in becoming one of the qualified networks on this Tefka-based exchange can now look at the contract, they can look at the technical specifications, and they can make a decision of, do they see this in their market interest, to participate in this network? So that's what I mean, that we're at the beginning of the beginning now. So now we've got a number of, potential networks. We're starting to, look over those documents, and participate in ongoing forums to, sort of get feedback and to, have further discussion about it. And we have a strong expectation that we'll have a couple of networks, hopefully minimally, a couple coming forward before the end of the calendar year to want to move forward with it.
Yeah, that's really exciting. And, while you've also mentioned how, this is during the town hall yesterday, you were like, we're not here to break news. We're here to, really share what we're doing. So, but in 2022, what do you really hope to accomplish? I mean, the Tefka piece is big. You mentioned the APIs. I know that USCDI version 3 is supposed to get rolling this year. So what are you most excited about?
What am I most excited about? One of the great things of having this job is that there are a tremendous number of things to be excited about. So it's it's hard to pick my favorite child here. But I'm really excited about Tefka and being able to hopefully get somewhat of an industry consensus to settle the question of what's the overall umbrella for nationwide interoperability? Is there an overall network umbrella for that? And the reason I'm excited about that is that since ONC's inception, and that was when I first got involved in Health IT as well in the early 2000s. ONC was founded in 2004. A nationwide network has been a part of sort of the ONC vision, literally for that long. I mean, that's what our first national coordinator, David Brailer, did a lot of work on. What would an architecture for a nationwide interoperability network look like? And since then, we've been, sort of having that as, being a part of the vision. And so now here we are with the foundation of, and one of the things that we found was that, well, it's really hard to create a telephone network if no one has telephones. So, okay, well, let's step back. We have high tech. Let's get everyone onto electronic health records, $40 billion investment, a lot of work. Great. Now everyone has telephones. Now we can rethink again, what a telephone network looks like. So that's where we are. And that part's really exciting to me about, getting us to a place that we can say, all right, now we have answered that question. Everyone knows what the North Star here is, and let's start pointing there. So that's one thing. I think the FHIR API enablement is another thing that I'm really excited about, because once we have that greater uniformity, we start to have individuals, meaning providers as well as patients, have what I would consider a more normal experience with the use of technology in healthcare. So being able to use your smartphone to do things in healthcare like you do when you use Uber Eats. And, that's the expectation that people have. And they always wonder, why is it so different? Why can I order a pizza or order a burrito and I still am having a problem? I can't even do that, with healthcare. So I think that's one thing I'm really excited about as well is working with the vendors to get that in place by the end of the calendar year. And then finally, the last thing I would mention is health equity. Health equity has been, not a front of mind concern in Health IT. And I think now, as we know, it's an administration priority and it's certainly an ONC priority. Thinking about all the different ways that we can make that a front of mind concern. And I think there are lots of opportunities for us to do this from a data perspective, as well as we look at algorithms and we look at other areas that can help us all move forward. So if we can change a little bit of the mindset this year, reflecting sort of a turning point, and all right, everyone sort of gets that health equity has got to be an issue that they're thinking about as a front of mind concern here, I think we'll have done a great job.
Yeah. So yesterday you were speaking alongside CDC talking about interoperability at the public health level.
You attended all the sessions.
Yeah, I know, that's my job. So, you have USCDI Plus, and then CDC has its own data modernization initiative going on. So in the public health space, we've seen how there's lack of data in certain areas, and that creates inequities in representation. So how are you coordinating with CDC to also improve interoperability at the public health level?
Yeah. So we're doing a ton with the CDC, and that's one of the things that that I've found really satisfying and gratifying about being in this role is our ability to work with other federal agencies, and the CDC is just kind of the poster child, I think, right now for the national need for us to be able to do this, and the great collaboration we've gotten from the CDC to say, hey, how do we join forces more to have everything that ONC has been doing with respect to interoperability being pulled in the direction of better enabling public health. So specifically to your question of the U.S. CDI, for example, the CDC has the Data Modernization Initiative, which is described very well, I think, on their website. If you go to the CDC website, there's a whole thing on the DMI. They call it Data Modernization Initiative. One piece of that is the data itself. So there's infrastructure, there's all sorts of technology components for applications and tools and all of that. But then there's a core question of what data are we talking about here, and how do we have greater consistency in that data? One of the challenges that we have, and with our public health system, is that it's actually not a public health system. It's decidedly not a single public health system. It is a loose confederation of 64 different public health systems, and then underneath that there's hundreds and hundreds of public health systems that are at the state, territorial, local, tribal level. And the CDC plays a role through funding and through policy to orchestrate and coordinate the activities of those public health agencies, but they don't have the full authority, command authority to say everyone has to do this. That's just it's literally in the U.S. Constitution. So, but technology can be an enabler to have greater orchestration across different entities, and to be able to provide everyone the benefit of having autonomy, which they need, but being able to have better opportunities for sharing. And so one of those pieces is this US CDI, the US Core Data for Interoperability. So the ONC requires that certified EHR vendors, which cover 95% of hospitals and 90% of ambulatory providers, we require that those EHR systems support a data model called the US CDI, the US Core Data for Interoperability. And that's I think of it as like the minimum data set of the healthcare delivery system. And that's, 25, 26 data elements plus 8 types of clinical notes that are required to be supported by those systems. Right now, with our public health system, you have 64 different jurisdictions who are kind of defining their own data models. And that creates, a lot of friction in the opportunity to be able to share it. It creates a lot of sort of overhead in being able to aggregate data from different jurisdictions and then try to, normalize that and then try to provide a nationwide picture for the jurisdictions to be able to share information with each other. It becomes really problematic and hard. So what we've been working on is saying, how do we use the fact that we've already got this base of electronic health records now across the country who are required to support this minimum data set? How do we say, how about if we start with that minimum data set as the starting point and build on top of that for public health needs? And can that help us get to a place where we have a true nationwide public health data model? And that can give us a little bit more systemness in a system that belies systemness. And so if we can get that kind of, and that becomes more of an opportunity. I mean, it's not about the federal government coming and saying, public agency, health agency, you are required to do this, in part because we're not, we don't have the authority to do that. But it also becomes something that this is an opportunity for all of us, and it'll make your lives easier as well if you start from that basis. So that's, just one piece of what we're doing with the CDC to say, we've got some levers already in the market. We can build on those in a way that, helps to accomplish that goal, and also helps to accomplish the better integration of the public health system with our healthcare delivery system as well, because that's one of the things we've seen in the pandemic as well, is that those two, very important, sort of systems, quote unquote, are pretty siloed right now.
Yeah, that's really important. So we have a few more questions here before we wrap up. And one of them is, since you are, you've touched upon so much that you're doing. So what are some of the biggest challenges amid juggling all of this work? And, what are you doing to try to overcome them?
Sure. Yeah. So, what are the biggest challenges? I mean, there's certainly always a challenge with, with the alignment of all the federal agencies. Every federal agency has got its mission, and they've got to be, have their heads down performing their mission. And certainly in the pandemic, every organization in HHS, is front and center, in helping the nation get through this. So, but, and that means that there are challenges with respect to alignment of all of these activities. And we've got, before the wide adoption of electronic health records, you didn't see that much activity by all the different agencies, trying to get more and more clinical information because it was so darn hard. But now we've got this foundation of electronic health records, and every agency, that's involved in healthcare is like, oh, I want to get more information out of this for surveillance. I want to get more information for safety. I want to get more information for research, and which is fantastic, right? It's a problem that we wanted to have. But one challenge now is saying, how do we have just sort of better alignment within the federal government in our basic approaches? Just what I was describing with the CDC, right? How do we, work with the FDA and NIH and CMS, and HRSA and ARC and all those different agencies. So I think that's a good challenge, but it's a challenge that, is fast emerging because there's more and more activity and more interest in, in getting that kind of information. So that's one of the things that we're doing behind the federal wall is, helping to coordinate that. And of course, we've got to figure out a way of doing that in a way that doesn't slow those agencies down, because they have missions to perform. We certainly don't want to be in the position of slowing them down. But on the other hand, we think there's a benefit to everyone in having, sort of better alignment of that. So that's one challenge. I think the other challenge is, from my perspective, thinking about what's the perfect sweet spot amount of regulation. Because I do fundamentally believe that because the healthcare industry is so fragmented on the supply side and the demand side, and because the federal government has such a large presence in healthcare, and because the federal government has such deep interest, obviously, in the healthcare system, I think that the role of regulation is really important in healthcare, as it is in a couple of other industries like finance, for example, but it plays a particularly important role. But I also appreciate, having been in the private sector in healthcare IT, for all of my health IT career up until a year ago, I also appreciate that there can be overreach, and it's really hard to sort of pull that back, and that can really have some deleterious effects on the market. So thinking really hard with the team of how much do we put in place that helps to help the market organize and point in the direction that they themselves want to, but their own competitive interests prevent them from doing that, but isn't so much that it actually channels innovation in a certain way, because we actually don't know what's the best way for innovation to be channeled, and I don't think the federal government should be the ones who are trying to dictate that.
Yeah, it's definitely a tricky balance. So now we get to the fun questions. We're here at HIMSS, and
it's already fun.
Oh, well, I guess everything's fun then, but it's always fun to talk about the festivities at the conference. So, you're here to talk about a different number of things. So for people who can't make it to all your sessions, what are some of the key takeaways that you really wanted to bring to HIMSS that you want the audience to walk away with?
Sure. I think that, the biggest one is that we are, we're at, and the term inflection point is used too cavalierly, I would say, in general, but we're at an inflection point. I think that we are really at the beginning of a fundamental change, I think, in paradigm in healthcare. And I want, just people, and maybe it's just a reflection of how old I am, that I have 20 years now in health IT, to be able to step back and appreciate the moment, to be able to say, people don't realize, I think, certainly younger people, I think, don't realize the long journey we've been on here, that starting in, 2000, 2001, when the Institute of Medicine first put out, its report on the medical error rate in the U.S., and we started to think about how could health IT start to solve that problem, and then we had no idea how we were going to get health IT in place. There was a big challenge back then of thinking about, and where the U.S. was kind of a laggard among industrialized countries, that Europe was way ahead in terms of electronic health record adoption, and we were looking to Europe and saying, gee, how can we accomplish, what they've accomplished? And then now we've spent a lot of time, a lot of money on building this foundation of electronic health records. We are now at the point where we can start to say, this is starting to be a digitally native system. And how do we just reconceive how healthcare is organized? How do we start that process? And that's not an overnight thing. That's not a thing that, happens because Micky Tripathi stands up and makes a speech about it. But I think it's important for all of us to just stop and say, just remember, everything that we've had to date is like an electronic layer on this big cake that is paper, bricks, and mortar. But now we have, the cake is actually starting to be bits and bytes. And let's stand back and appreciate the moment of that, appreciate the innovation that can happen, and start to rethink some of the fundamental, sort of ideas that we've had about the way healthcare should work. And let's think more creatively about healthcare, how we want healthcare to work. And I think that's the opportunity we have in front of us.
Yeah, it really touches on the whole theme of the conference, which is to reimagine healthcare. So I'm glad you're aligned with that. And lastly, I know you're here till tomorrow. So what are some key sessions that you're trying to see, if any at all? And maybe if there's an overall theme that you think will appear across the conference, what do you think has really emerged? The showroom floor just has so many different things going on. So curious to see what you have to say about that.
Yeah, I will say I don't have any particular sessions that I'm thinking about, but what I am really looking forward to, I've said this to Kevin a couple times, and I'm really going to do it today, is going out on the showroom floor. I love, for me historically, that's what HIMSS was about. I would try to attend certain sessions, but it was really about being able to get out on the floor, see the established vendors as well as the small innovative vendors, and really be able to talk to people, about what they're doing, and sort of seeing what's the pulse of the industry, and being able to see different dimensions of the different vendors that you don't really see. You can talk to them on the phone, you can talk, you can sort of have those meetings, but this is where you get the opportunity to dig a little bit deeper and really get that perspective. So I'm really looking forward to getting out in the showroom, and it'll be interesting now that I'm in this new role, what that feels like. I used to do it a little bit more incognito. I guess now I'll have a little bit more of a beacon on me, but I'm really looking forward to that. And I do, some of the themes, we'll see what it is out there, but I'm going to anticipate that there's going to be a whole, sort of set of themes related to algorithms and the ability of AI and ML to be able to creatively help us, sort of solve administrative business process kinds of things, as well as better clinical decision making. And this is where it overlaps with the second theme I think is going to be out there, which is probably social determinants of health and health equity, and how we think about health equity. And obviously there's an overlap there as well, where algorithmic approaches can be a benefit. They can also be a harm. So that's what I'm looking forward as well.
Well, fantastic. I think a lot of us are also looking forward to those things. And, I hope you find some cool stuff on the show floor. I know there are plenty of free cookies and cupcakes and goodies out there. I'll try to stay away from those. But thank you so much, and I hope you have a great rest of your conference.
Great. Thanks. You too.
Thanks for tuning in. Follow our other shows for more coverage throughout the conference this week. And head to govciomedia.com to keep up with our HIMSS coverage. We'll be covering some key sessions, and we'll release daily newsletters so you don't miss a thing.
HealthCast, along with GovCast and CyberCast, is a production of GovCIO Media and Research. For more podcasts and to check out the other shows, head to govciomedia.com. Watch out for new episodes released every Tuesday and Wednesday across our shows. You can follow all of them in your favorite podcast platform, and if you like what you heard, make sure to let us know by leaving a review. And if you have any topics you think we should look into, contact us at newsletter@gcio.com.